Welcome back, everybody. It is my great pleasure to introduce our next keynote speaker, Dr. Scott Leatherdale, a full professor and university research chair at the School of Public Health Sciences at the University of Waterloo. Dr. Leatherdale's research focuses on advancing a systems approach for primary prevention and evaluating population-level health interventions. The core foundation of his research program is the Compass system, which is a prospective cohort study following more than 75,000 Canadian youth to evaluate how ongoing and real-world changes to programs and policies affect outcomes. Scott is a generous collaborator who I've had the pleasure of working with for quite some time. He's also a personal inspiration. He has coped very courageously with recurrent colorectal cancer, and he's spoken eloquently and poignantly about the challenges involved. It's a real testament to him as a consummate scholar being here today and presenting his work, so please join me in welcoming Dr. Scott Leatherdale.
Thank you. Thank you very much for having me today. If we could get the title slide up. Just before I start, it's a little bit fuzzy, sorry about that. I don't know if that's on my end from the slides or the background, but I do want to thank my funders. This work was funded by CAHR, Health Canada, and the Public Health Agency of Canada. And I also have a large leadership team of folks who help me from across the country, and there's about 25 other co-investigators across the country and about 55 graduate students now working with the Compass data who make this work possible. As an overview, I do want to give a bit of background on Compass, mainly because it may be a data source a lot of people aren't aware of. It's also something where I want to try to tell you what we have available in case you want to use some of the data for your research. We function as an open data research program where we share our data with anyone who wants to use it. I'm going to talk a little bit about pre-legalization changes with youth, because that's really important in the context of what happened with kids in Canada. Then we'll obviously talk about what happened post-legalization. It's hard to talk about what happened with kids if we don't also address the issue of what happened with COVID-19. And then I'm going to ramble on about some other interesting findings that are cannabis related from Compass. As a background, so we're a prospective cohort study. We started in 2012. We're currently funded till 2028. And what we're doing is we're collecting longitudinal data, and it's hierarchical. So we're following a cohort of secondary schools in Canada, and then we're also following the students that attend those schools longitudinally over time. We're primarily focused on grade 9 to 12 students in secondary school. In Quebec, this would be secondary 1 to 2. And so what we're doing is we're tracking what's happening at schools, but we're also tracking what happens with kids within those schools. We're not a representative survey. You hear a lot about representative surveys. So CSTADs with youth, HBSC with youth. I'm part of both of those survey systems. We're purposefully not representative because we use active information passive consent procedures in Compass. We only approach school boards that allow active information passive consent. This is really, really important for anything focused on substance use with kids. Oh, I already switched my slide, sorry. I don't know how to go backwards on this. I'm just hitting buttons. Passive consent is really important. For a lot of the studies where you see what's happening nationally with kids, so for example, CSTADs, it uses active information, active consent procedures. You have to get parents giving permission for kids to participate. Really what that means is you get low participation rates. Typically it's around 20 to 30% or even lower. And it means the kids who are using substances are often the ones who aren't even participating because they don't want to ask their parents for permission. We use passive consent protocols that gives us a more accurate representation of what's happening in youth populations in Canada. As part of the HBSC team, which is the WHO-funded study in Canada that is nationally representative, when we compare our sample to the HBSC samples, they're almost identical. So even though we're not nationally representative from a sampling standpoint, our data look the same with respect to demographics of what you see in those samples. We just have more kids who are substance users participating. We are a convenient sample of schools because of this. And we initially were just funded to start tracking a cohort of kids in Ontario, but there's been an increased demand from stakeholders, both within the school and education systems and from public health, because of how hard it is to find longitudinal data on kids. So we've been expanding rapidly. So for example, we just finished last year's data collection. We're just over 82,000 kids. Now I'm going the wrong way with the wrong button, sorry. So again, just as a bit of an overview, So we started in 2012, and we've been tracking schools and students since that time. We originally were funded just to start in Ontario. You've heard a bit about natural experiments. We were interested in those ideas, so we were good with our funding, and we had some money left over, so we sampled a group of students in schools in Alberta so we could do some policy evaluation for some policies that were changing in Ontario related to the Smoke Free Ontario strategy and using Alberta data as control group data. In 2015, 2016, Health Canada got interested in what we're doing, and the Substance Use and Addictions Program funded us to expand to British Columbia and Quebec, which also meant we were able to translate all our tools and all our knowledge exchange tools also into French. The reason SUAP funded this is they knew with legalization coming down the pipeline, they wanted us to have a larger sample, and they wanted to have data from students in Quebec participating. I think Dave already lobbed the ball in the air of why it was important to have students in Quebec participating in this sample. If you look at the samples we had available around legalization, pre-legalization we had data from just over 66,000 kids, post-legalization 74,000 kids. We were in the midst of our next data collection cycle in 2019-2020, and then COVID happened, so we had collected data from about 29,000 kids. COVID happened. Closure of schools was not a good thing for a school-based study. So we rapidly transitioned at this time. It took us about 2 weeks to transition from a paper-based survey to transitioning to an online survey. That's why our sample in 2019-20 AC is from about 9,600 kids. That happened, those data were collected in March and April when COVID first started. Very valuable data to have longitudinally from kids. And then you can see we've ramped back up to what's our traditional data collection cycles. To get you excited about wanting to use the data moving forward, we were funded by FACT this year. We expanded to Prince Edward Island. The data are seeming to be really valuable. We actually have a census of schools in PEI. Every single school and student in PEI is participating because public health there is using the data we're collecting to actually inform all the school-based programming. I'm not allowed to tell you this. I probably shouldn't be talking about it. My partners will get mad at me, but I couldn't resist. We're also starting to expand this year to a census of schools in Quebec. So we'll have our sample now will be upwards of 550,000 kids a year moving forward. So we may not be nationally representative, but census samples provincially is even better. What do we collect? I said it was a hierarchical study, students in schools. So at the student level, we use a student questionnaire that collects information on students every year. You can treat these data as repeat cross-sectional samples or as linked longitudinal data. Then we also collect information on what's happening in the school environment every year. And I'll go over these in a little bit of detail. Prior to COVID, we were a paper-based questionnaire. This was consistent with CSTADS and the HBSC, where we had these questionnaires designed to be completed in one classroom session and collected a whole bunch of data on lifestyle factors associated with kids. We're not a cannabis-specific cohort, but we did have measures available on cannabis because we're interested in substance use. We also have a whole bunch of data on other lifestyle factors associated with youth health, which can be really interesting when you want to start looking at how cannabis relates to other behaviors that kids are participating in. Then I said COVID happened. So we transitioned to an online data platform. We were fortunate. The University of Waterloo had a site license for Qualtrics. So we took all our tools and translated them to an online format. But once we did this, we also had the capability to add more nuanced questions around cannabis because we also got some specific funding from the CCSA at that time to look at cannabis as one of the cannabis teams. So we started including additional information. Trying to be proactive for the next thing that'll be coming down the pipeline that the feds are interested in. We also started measuring psilocybin use in kids because as we move closer towards different regulations or legalization of psilocybin, it's important to also have that information available. We also started collecting some new demographic information that's relevant. We do whole school samples, so we're collecting data from every kid in a school every time we're collecting data. But we ask these simple questions at the beginning. These are non-modifiable questions that kids answer within a school, and then we developed an algorithm. This is what allows us to give each participating student a unique identifier so we can track them over time without ever knowing their individual information. So we have no names of kids who are participating. The only names of kids we have are kids who aren't allowed to participate. But we can use this linkage algorithm to be able to track kids individually over time, which is really important. Confidentiality is a really big issue when you're doing adolescent work for them to give honest responses on surveys. If they think there's the ability to identify them, they'll start lying on the surveys. We do this because A, it lets us track them, but it also ensures they're giving us accurate data. So that's what we do with students. For every behavior we're measuring with students, we also look in the school environment and go, what are the programs or policies that students are exposed to? So specific to cannabis, every year we know exactly what schools are doing for curriculum, programs, or policies around cannabis prevention. We know this around each of the different behavioral domains we track. We also feed this information back to schools to go, here's what's going on with your students, and here's the program and policy environment you're providing. You may want to do something different, or you may want to keep doing what you're doing. We're interested in the built environment too, so each year when we're collecting student data and the program and policy data, we also map on the built environment surrounding the catchment area for every school, what may be of relevance to people here. For example, is we can map on where all the cannabis retailers are located around all the participating schools in Compass. Work I did years ago with tobacco use showed this was really important. When we were looking at smoking onset in kids, we knew that tobacco retailer density played a really important role in the likelihood of kids starting smoking. They've already kind of alluded to this with, as kids walking to middle school and high school, seeing all these retailers. We can do the same kind of work with the Compass data. How does retailer density surrounding schools actually influence the likelihood of kids starting to use cannabis? We also then link the data every 5 years to the Canadian census data. This gives us good demographic information to know whether, kids coming from more affluent school catchment areas or poorer catchment areas, for example, what impact does that actually have on the likelihood of kids participating in these things? It gives us a lot more nuanced way of doing our analysis to identify who are the actual at-risk populations of kids. Few people have talked about natural experiments already. I like to lecture to people. I'm a professor, so I had to put a few educational slides in here. Sorry about that. But within this cohort, we're identifying that each year thousands of different programs or policies are changing within schools every year. And all of these represent different interventions that we could evaluate through natural experiments. We can look at them with the repeat cross-sectional data, or we can also look at them with the linked longitudinal data, depending on what we want to answer. Cannabis legalization was an excellent opportunity for us. When we initially started in 2012, we were not interested in doing really much around cannabis. That wasn't our priority at the time. But once people started talking about cannabis legalization, we realized we had the only longitudinal data with kids, with multiple years of data collected longitudinally prior to legalization happening. Excellent natural experiment to evaluate. For people in the room, you have the randomized control trial. That's ideally the gold standard design for evaluating things traditionally. We use these quasi-experimental designs, and really the only difference when you think of it, instead of randomizing people to groups, you can't randomize people to a policy. People are part of that. We're not randomizing, but we're still tracking people over time, pre-post. If you think of a traditional experimental design, and Amanda already alluded to this, you have an intervention in a control group. Then you have these non-experimental designs where there's no control group. This is important for me to say for Compass with respect to cannabis legalization nationally. We don't have control group data for examining cannabis legalization. For that to happen, we would have had Compass data collected in another country to act as a control group. We can have control group data if we're looking at how one provincial jurisdiction implemented aspects of the policy relative to another. So for example, what Quebec did relative to Ontario, Alberta, or BC, we can do that. But federally, we don't have control group data. That doesn't mean it's not important what we can't answer. We still have these beautiful interrupted time series designs where we have multiple waves of data of what was happening with kids before legalization, and then we have multiple waves of data of what happened after legalization, where cannabis legalization is our intervention. The last wave of data we collected before things became legal was our 2017-2018 wave of data. We call it 2017-2018 because we work on school year cycles. That's why it's 2017-18. The 2018-19 wave of data, we purposefully delayed the start of our data collections to make sure nothing was collected until after cannabis had been legalized. So that was a clean post-intervention data point for this. So hopefully this makes sense to everyone. I said pre-legalization was important, so let's just look at some of the basic stuff that came out here. So this is what we found in the kids in the cohort from 2012 up until 2017-18. So this is all pre-legalization data. You can see what was happening with every use of cannabis and current use, where current use is past 30 days. What we found really interesting is cannabis was actually trending downwards among youth in our samples. You saw similar things in the HBSC and CSTED. Then all of a sudden there was a lot of public discourse happening around cannabis legalization. This was all the amp up before things became legal. That's when we started to see things change with youth. We actually saw an increase in current use in youth happening over time before legalization, but it all happened immediately after there was a public discourse around this was going to happen. Historically, you could see cannabis use was higher among males and females, but among both males and females, as soon as there was this public discourse happening, we saw an increase in current use. Every use isn't always the best indicator because someone could have tried once and then not smoked again. We're not necessarily interested in those individuals as much. I like current use more, and you can see here there's an increase in both males and females once we started talking about legalizing cannabis. When we look at within the current users, those who are using weekly or those who are using occasionally, the increase we saw in current use was actually driven by occasional users. To us, this means once we started talking about this was going to become legal, we had more youth trying cannabis to see what it was like. It wasn't the people who were already using on a more regularly established pattern. It was people experimenting with their use started to increase. With respect to cannabis access, we also saw things were trending down. The vast majority of youth in Canada always saw cannabis as very easy to access, even when it was illicit. But you can see here, once we started talking about it becoming legalized, more youth started to see it as becoming very easy to access cannabis if they wanted to use it. This is among users and non-users. So even youth who had never used cannabis started to say, yeah, it'd be definitely easier to get it if I wanted to get it. Now let's start talking about some trends post-legalization. And what you can see here is current users, so that's past 30 day. Occasional users, those who have used but haven't used in the past month. So those are people who've used it before in the past year but haven't been using more recently. And never users. This is when legalization occurred, and you can see that over time we actually saw a fairly large increase, relative increase in cannabis never users over time. So this is a good thing. Over time, the number of kids who had never used cannabis increased, and this is pre-post legalization. You can also see a decrease in occasional users and a decrease in current users. This is often something people like to celebrate. This is good news. You know, things became legal and then we saw a decline in youth. Just remember, for all these youth, they're still technically under the legal age to use cannabis. So this is still not the best feel-good story, but things were trending in the right direction. It's hard not to talk about this though without talking about what happened with COVID-19. Because you can see COVID-19 happened between the 2019-20 waves. BC is before COVID, AC is after COVID, all collected in the same school year basically, but right before it happened and then right after it happened, you can see sharp declines. So I'm going to ramble on a little bit about what was happening with COVID because I think it's important in this discussion as well to consider this. Youth are very different than adults with how they were able to socialize and use cannabis over this time. This is just a different way of presenting the same thing, a stack graph that just shows there was this general downward trend and then it declined a bit sharply after COVID-19. But some people in some discussion groups were worried about after legalization, maybe I should have said this earlier, that there'd be a sharp increase in use among kids. I remember that was one of the large concerns for the people in my world, what people were talking about. Once it's legal, you're going to see a sharp increase. We didn't actually see that. We saw the little bump when we first started talking about legalization, and then things started to decline. Incredibly complicated graph. You can tell Amanda and I work together. We have the same way of talking about these things. You don't have to memorize all the numbers. But what we wanted to look at here is we had two cohorts of students we wanted to look at, and we wanted to adjust for age-related changes in cannabis. Unlike adults, where Andre said, you know, as people are getting older, they tend to wean off cannabis, and youth populations, as they get older, they tend to be, onset tends to ramp up. So we looked at the kids who provided data 2 waves before COVID, then COVID happened, and 1 wave post, and then a cohort of kids, and this is longitudinally, where it was 1 wave of data and then 2 waves post-COVID to see the impact COVID may have had on their likelihood of using cannabis. And the short of the story here is, among monthly users, weekly users, or even the highest risk kids, daily users, and yes, there are daily users in our sample, it's around 0.6% usually, you can see over time, even adjusting for age-related changes, you would expect to see increases. Oh, I hate this clicker. We saw a decline in monthly cannabis use, a decline in weekly use, and a small but non-significant decline in daily use among kids over the COVID period. So COVID did have an impact on attenuating cannabis use in kids that you would expect above and beyond what was just the regular developmental trajectories. So COVID sucked for a lot of people for a lot of reasons, but the people working in the youth health area, one of the things we saw was the best intervention we've ever seen for reducing substance use in kids. Alcohol went down, cannabis went down, smoking went down, vaping went down. Wonderful intervention. Sucks socially, but wonderful intervention. We also know that kids behave as social creatures. It's what drives them a lot of the time. So we were interested in what happened with the learning modalities kids had. And kids in Ontario, these are Ontario-specific data, bounced around between learning at home, parents in the room remember how wonderful that was, to going back to school, to some kids staying at home. And one of the things we found that was, after legalization, cannabis use was steadily decreasing. COVID happened, massive decline among all the kids. Really because they were stuck at home with their parents. Most kids who are using cannabis, if you ask them, would say their parents do not know they're using. So when they're stuck at home, use went way down. Oh, sorry. Then things opened up a little bit. Some kids went back to school, some stayed at home. When things opened up, we saw an increase. Things started to normalize among the kids who were back socializing with their peers. Then there was a closure again. Things tightened up again. Then when they went back to school, you can see for the kids who went back in person, it started to increase again. Very different behavior when it's kids socializing with other friends outside of the parents' view. But still a decreasing trend. One of my grad students was interested in looking at whether or not over this period of COVID, post-legalization, if kids were using cannabis to cope. Not many kids who were current cannabis users actually reported they were using cannabis as any kind of coping mechanism to deal with the impact of COVID, only about 4%. More kids, if we looked at cigarettes, would say they were using cigarettes to cope, but it wasn't really common in kids in our sample. So cannabis wasn't a coping mechanism for kids dealing with COVID. So let's look at a few more waves of data after what happened with COVID-19 to see, okay, we're kind of coming out of the pipeline now for kids of this. They've had more years of what's relatively normal living of their lives and what's happened. Well, legalization happens there. You can see there's still a downward trend. So this is generally a good thing. And you can see there was still an upward trend in never users. Where over time, since cannabis pre-legalization till last year or 2 years ago, cannabis use, never use increased by 12% relative. So that's a good story. Current cannabis use also decreased, and occasional cannabis use also decreased. So I would say, post-legalization, although there's a large number of youth who are still under the legal age to use cannabis, things have been improving since legalization. It may have started prior to legalization, but it hasn't been getting worse. If you look at things just from COVID-19 time forward, you can say there was a large increase in current cannabis use, but I think this can be a little bit misleading. It's still substantially lower than it was before COVID-19 happened. So even if we ignore what happened with COVID, I think we're still in a better place than we were with respect to use. If we look at some of the sex differences in our sample over time, you can see when legalization occurred in COVID here, just to show you, this is the waves of our sample over time. Occasional use was always higher among females than males in our sample, and this has happened in every wave of Compass for occasional use. Pre-COVID, you can see that current use was higher among males, and we've seen data presented to this today. In general, males use more cannabis than females pre-COVID. Post-COVID, horrible timing. Post-COVID, big switch. All of a sudden, it's being used by more adolescent females than males. Something dramatically changed when COVID happened. We'll allude to this a little bit later. But now it's higher among females than males. There's been very little attention paid to this. So not only are more females using frequently. They're more using occasionally, but also more using it more frequently. In terms of modes of cannabis use, I don't even know where the slide is here. Where did the graph go? This was a really cool graph. Uh-oh. Okay, what this was showing is modes of cannabis use, how kids were using. Vaping, smoking, edibles are the primary modes of use among kids. Trust me, the slide was on there when I made this. I'm not sure where it went when I transferred it to here. But since over time, we saw smoking was always the most common form, similar to what Dave showed. But then we've seen a steady decline in the number of kids who were primarily smoking cannabis. There's actually been a 16.8% decrease since COVID started in those who are using. I can forward these slides to anyone who wants to see the actual numbers. We've actually seen a rapid increase in vaping of cannabis in youth in the past years. This was the line I really wish where this stupid slide would be showing. A sharp increase in vaping of cannabis in youth populations. 158% increase in a 2-year period of time. Edibles remain fairly constant. About a third of kids are using edibles. So the takeaway that you can see here that I want you to remember, in the past 2 years, 2021, 2022, massive increase in the vaping of cannabis among youth. Remember what Dave was saying about how high the THC content is in vapes? Incredibly high, lots of exposure. Ease of cannabis use, this isn't going to show you those data either for some reason. The vast majority of youth over time report that it's very easy to access cannabis if they want to get it, regardless of whether or not they're cannabis users. That's the take-home message from here. So one of the goals with legalization was to reduce youth access. In general, youth don't find it any harder to access since legalization came into place. So I'm not sure why these aren't showing up, Jane. It's beyond me. But solitary cannabis use. Oh, this was another good one. You guys would have loved these figures. Solitary cannabis use. This is one where kids report that this isn't them just using cannabis. This is kids when they're by themselves in a situation where they're not with their peers. Are they using cannabis to get high? And what we found is after legalization, solitary cannabis use was not a big deal. If I remember the number correctly, it was around 90% of kids were never using cannabis on their own. However, past 2 years, once vaping became more common, we saw a sharp increase in the number of kids who were cannabis users reporting that they were using cannabis on their own. Okay? So you can see the number there. I think it jumped from about 6% up to about 35%, if I remember the number correctly. An 823% increase in kids reporting that they're using cannabis on their own since vaping of cannabis became more popular. Oh, I'm so disappointed these slides didn't show up. Some conclusions from this. So I think it would be safe to say since the onset of the Cannabis Act, there's been an overall decline in the frequency of cannabis use among youth in Compass. So this is good news. It's primarily driven by declines in current use, which is also good news if you think of frequency of exposure. Less exposure is a good thing. We've also seen a slight decline in youth perceiving cannabis to be easy to access, but it's still nowhere near where it should be. Since the onset of the COVID pandemic, there's been an immediate decrease in the frequency of cannabis use among youth in Compass. So as soon as COVID happened, we saw a sharp decrease. It's rebounded slightly, but nowhere near the levels of what it was before the COVID pandemic. So we are seeing these overall declines. There's been a large and rapid increase in the frequency of current cannabis use. Or frequency of current cannabis users reporting solitary use. I think that's a really big issue moving forward. Kids who are using it when they're on their own, not for the social benefits they often talk about. We also found that frequency of cannabis use is higher in females than males. That's an interesting thing that's happened in the past few years. And although smoking remains the most common form of consumption, vaping cannabis is becoming much more common, and this is happening quite rapidly in youth. Some other interesting findings. See, I'm not sure why certain imaging isn't showing up here. I had a cute little Compass logo up there. This is some research from other people on my team. Amanda's the doggett who's up there. She'd be happy to talk about some of this too. One of the other concerns we have with youth using cannabis is it's related to a lot of other negative things. So transitioning to more frequent cannabis use over time is actually related to a bunch of other negative outcomes in kids. Kids who use cannabis tend to do more polysubstance use, where polysubstance use is using lots of substances at the same time, alcohol, vaping, cigarettes. They tend to be more physically inactive, and they tend to report substantially higher screen time. 2 in 5 cannabis users expanded their modes of cannabis use since the start of the Cannabis Act. So before things were legalized, traditionally kids really only used in one form, and it really seemed to be primarily smoking. Ever since it's been legalized and there's more options widely available to them, they're using a lot more options. They're vaping it quite commonly, and they're also eating and drinking it. So this is something to consider moving forward. One of the things, we also have a large number of people in my team are interested in mental health. And we found that consistently across waves of Compass, cannabis use doesn't necessarily appear to be related to anxiety among youth in our sample, but it does seem to be related to depression. And we have a lot of people looking into this now because it's not clear how there is the link with depression. It seems to be bi-directional. Some kids are depressed and start using cannabis as a coping mechanism, and then we also find some kids are using cannabis and then develop depression. So we have more people looking into this with our linked longitudinal data. We also know that cannabis use is also occurring with other substances, primarily drinking and vaping, that are also related to mental health in youth populations. Some other interesting findings. It's really hard to find a cannabis user who also doesn't drink heavily and or also vape. So if we're going to do anything around cannabis prevention in kids, I think we need to take a more comprehensive approach of looking at the whole risk behavior profile of kids. It's really rare to find kids who are only using cannabis as a substance. They all follow similar patterns of development, and they all tend to develop at the same time. So again, polysubstance may be important. I just got these data last week from one of my postdocs, so I wanted to show them to you today because I think this is interesting. It's a different way of trying to look at some of the data we had in Compass. And I know it's trendy, but one of my postdocs wanted to apply a machine learning lens to what do we actually find with our Compass data pre and post legalization. Where machine learning, it's basically a computational technique where you let the computer do the thinking for you. You input the data you have, it finds the best algorithms for whatever you're trying to answer, and it gives you the result with, taking away the bias of researchers. That's potentially one of the simplest ways to describe it. And it's really quite good at predictive analytics. One of the tools you can use in this type of research is decision trees. And what decision trees let you do is they let you segment populations into different groups. So for example, if we want to look at cannabis use, yes or no, you're a current user, you're not a current user, it can let you branch down to figure out who are the groups that have the highest probability of having a particular outcome. These kind of machine learning approaches are really good if you have large data sets or you have really complicated data sets. Where I like it is, as researchers, we tend to have our own biases of what things we put in predictive models and why we put them in predictive models. The perk of something like machine learning is it takes all your available data and it looks for what comes out when you take away the biases of the researcher and you're just driven completely by what the numbers are saying. So what Kate did, so this is Kate Batista, one of my postdocs, she wanted to go, okay, let's take the 2 samples of kids. We have a wave of students who provided their data before cannabis was legalized, and then we have a wave of kids who provided their data after cannabis was legalized, and these are kids who have ever used cannabis. So it's not the whole sample, but these were the at-risk kids we were interested in. And then she ran these CART models on them to see what factors predicted cannabis use in 2017, and then what factors predict cannabis use now using the exact same measures that were available in Compass to see, are the things driving cannabis use before legalization the same things that are driving cannabis use now? And this is what I thought was pretty neat from the work she just did. There's big differences in why kids are using cannabis now compared to pre-legalization based on this approach she used. So in this table, you can see The percentages are the importance of the indicator on whether or not someone is a current cannabis user. So in 2017 and 2018, you can see these are the predictors that are really important, 2017-18 on the left, and on the right, this is what's from the 2021-22 data. You can see many of the risk factors are common across the years, but there's also lots of things that have been changing. So the top predictors of current cannabis use in 21-22 were depression and happy home life. Whereas something like the value of getting good grades was consistent between the two. The take home when you look at this is prior to legalization, the role of mental health in predicting current cannabis use was relatively small. In more recent years, post-legalization, but also post-COVID-19, the role of our mental health indicators are becoming substantially more important. Very simple way of looking at this too is at that time we also saw a big shift in females becoming more likely to be current cannabis users than males. We also have lots of evidence in our sample showing that depression, anxiety, and emotional regulation are problematic more commonly among females than males in our sample. So what's predicting cannabis use in our cohorts of use is changing, and it's changed in the last few years. I think this is pretty interesting. This is a different way of looking at those data in a slightly more easy to interpret manner. This is our pre-legalization data. If you looked at what predicted current cannabis use using machine learning, basically we found 6 profiles of risk in kids. This is what the computer said. This is basically the best way to predict current cannabis use in kids. And there were 6 different profiles. You had the lowest risk group, where about 5.2% of them were students who strongly valued getting good grades and had under $20 a week of available spending money. So their likelihood of being a cannabis user was around 5%, but they represent about 25% of the kids in the sample. The highest risk group, their likelihood, if you had these characteristics, your likelihood of being a cannabis user was 26.9%, with students who placed a lower value on getting good grades and spent a lot of time in the day texting. And this was about 1/3 of the sample. So you can see the lowest risk group were kids who didn't have a lot of spending money and valued getting good grades. The highest risk group were kids who they placed a lower value on getting good grades. They didn't care about things academically, and they spent a lot of time on screen time. So that was pre-legalization. Post-legalization, we now have 11 different profile groups. So things have changed dramatically in terms of the segmentation of these kids in our population. The lowest risk group was students who ate breakfast daily and had under $20 a week in available spending money. So basically similar to what we saw pre-legalization. These kids didn't have any money. And it represents about a 1/5 of the sample. The highest risk group, or the likelihood of them being current cannabis users, was 27% and was about 20% of the sample overall, with students who didn't eat breakfast, placed a lower value on getting good grades, and had high anxiety scores. So some of our thoughts on this, and I'd be interested in other people's interpretation. Traditionally, indicators of disengagement, so having low value on getting good grades, putting minimal effort into homework, having a lack of school connection, low educational aspirations, were key risk factors for cannabis use prior to legalization. Those were the kids who were really your largest group of at-risk users. Their relative influence of those characteristics has decreased somewhat, but that doesn't mean they've gone away. So academically disengaged youth are still more likely to be cannabis users than those who are academically engaged, but they're not as important as they used to be. The emergence of mental health risk factors, CSD-10, which is depression, GAD-7, which is anxiety, DIRS is emotional regulation, and measures of flourishing, that's overall whether the kids are thriving, yes or no, as well as having a happy home life and being bullied, since legalization have become more important predictors. So this suggests that, to me, this suggests that youth are turning to cannabis more now as a coping mechanism since legalization and since COVID. We'd have to disentangle those than what was happening previously. One of the things I do like saying in meetings like this, especially since I know there's a lot of grad students here, I gave the whole blurb at the beginning of what was available in Compass. We have gobs and gobs of data. If anyone wants to use these data, we are very happy to collaborate. We share data with any researchers who are interested in using them. We're willing to share tools and resources with anyone who wants to use them. We also have a team of statisticians in-house in my team at Waterloo. So if anyone has an interest in these data, like, oh, I'd be interested in seeing how tobacco retailer or cannabis retailer density predicts cannabis onset in kids, but I don't have the expertise to do those longitudinal multi-level models. We can provide that expertise in-house for people who want to partner on those kind of papers or research projects moving forward. We always prioritize student trainees. So if anyone's applying to use our data and they want a particular topic, if the student's asking for the topic, we always prioritize the student over established faculty members. But then what we try to do is link those students up to the network of faculty members that exists nationally, so you can have a mentorship group in that area. And we're always interested in proposals to expand or move things forward. I always put a picture of my kids up, because even if people didn't like my talk, they always liked the picture of my kids. And then happy to answer any questions. I'm really sorry that the slides didn't show up. Those were my two most interesting slides I thought they didn't show up, but I'm happy to share them with people after. Well, that's nice and quiet. Hi there.
I was wondering if you have any insight as to where the youth are getting the vapes to use. Like, are they taking them from their parents or buying them? Or?
So we do have some information on source, and this can go for any of the forms of cannabis with the kids. The kids aren't purchasing them directly from stores themselves. Common outlets are friends, which has always been something with the youth as they're using things illicitly, and family is also something. What we don't have the ability to do, I wish we could kind of have the social network analysis kind of thing to figure out with these kids. Is it one kid that's supplying for a whole school, or is it within social networks of small groups of friends that are supplying? We also know with vapes, you only need one vape for the kids. You know, youth behave often very differently than adults. Sharing of vapes is incredibly common with the kids. So all you need is one kid in a social group to have a vape, and then all the kids in that group can also share on that vape, which comes with its other own risks. But that's one of the things we're starting to look at now. The where kids are accessing these products, we only started measuring 2 years ago. So we don't have any of that information pre-legalization. The downside of us trying to be a cohort that's answering a whole bunch of things for a whole bunch of different stakeholders is historically we didn't have tons of information on what was happening with cannabis use, but we're getting a bit more nuanced with that moving forward. But that'd be something interesting to explore.
Very interesting. Thanks so much.
Oh, hi. Sorry,
Hi.
It's hard to see over the lights.
No, that's okay. I don't have any tough comments for you today, so don't worry. My question, the group who are vaping and are doing it alone, what do you think about the role of cannabis use disorder? And did you collect data on cannabis use disorder in your sample?
We don't collect information on cannabis use disorder just because of the amount of space we have available in the questionnaire, and we're trying to collect all this information within, one school period to keep our samples high. For the people on my team who've started looking at the data more recently, so we haven't published on this yet, but we're starting to look at what's happening with the kids. Because I have a PhD student who her whole topic is going to be looking at what's happening with kids who are using cannabis, solitary cannabis use, also solitary alcohol use. She's looking at them both. They have a risk profile that's high for a whole bunch of things I think a lot of people in public health would be concerned about. High levels of depression, high levels of anxiety, lots of bullying commonly experienced in those groups, low levels of activity, high levels of screen time. So it's just trying to figure out what's driving that. It seems they're a group of kids that are at risk for a whole bunch of things, but they're also not just vaping. So they're also the kids, it seems like they're vaping cannabis, but they're also smoking cannabis, they're using edibles, they're finding multiple forms to use it. We can't, with what we have available, discern, are they specifically vaping cannabis when they're alone? yes or no. We can't discern that with the data we have available. But to me, it would actually make sense on the way kids behave. If most of the kids we've talked to, their parents don't know they're using these substances. If you want to hide it, it's probably a simpler way to hide it relative to, say, smoking. Edibles would also be an easier form as well.
I guess the other question I would have about those kids who are using in isolation is, are they also starting to experience psychosis symptoms as well?
Yeah, and we don't have those data. The closest we could come with what we're available to asking kids for this age group with passive consent protocols, we'd be able to say whether or not they have clinically relevant depression, clinically relevant anxiety. We can't go into anything in more detail beyond that for what we're allowed to ask with these kids, unfortunately. That being said, this is the type of thing, if people are doing other studies with kids where they can collect other data, this is kind of good precursor information to say, hey, if you do have the availability to delve into this more within your own research, it's probably something worth looking into, because we just can't within what we're trying to do. Thank you. Hi there.
Hi, thanks for the interesting presentation. I just had a clarifying question. So when you were presenting the risk factors for cannabis use towards the end, were the risk factors collected at the same time as information on cannabis use?
Yes.
Okay, so you could say they're kind of correlated, per se?
You could say they're correlated, but when we also map these things longitudinally, I think we're not doing the causal models trying to say, this is definitely the cause of X, Y, and Z. But we have a lot of confidence when we're in our longitudinal sample and we're looking at this is predicting ongoing changes in these kids over time when we're controlling for all these other risk factors. We're pretty confident. I'm not going to use the causal language because then all the epi people in the world will get upset about it. But I would say there's very strong associations that would appear to be aligned with what you would expect if something were resulting in something changing.
Okay, thanks.
Yeah.
Did you ever look at say collecting the risk factor data for one school year and then looking at the cannabis use the next year, or?
Oh, so we could do that within our samples. So that's the nice thing. So you could say, here's a risk behavior profile of kids at time 1, and then what predicts their cannabis use at time 2. You could select all kids at time 1 who have never used cannabis, for example, if you want to do a specific sample in them, and you could model things that way. Or you could purposely select, I want to pick kids who've never used cannabis but also have strong scores for, say, emotional regulation. You could really target particular groups of kids in the sample, and our sample's large enough, we're around 75,000 kids, where you could kind of do that segmentation and then model what's happening with them specifically.
Okay, thank you. I just had one other clarification question. When you were talking about controlling for age, looking at the increase in cannabis use during COVID-19, I was just curious if the data you presented before that, with the increase in cannabis use pre-legalization, but when conversations around legalization were beginning, like 2015, 2016, if that was also controlled for age?
For what I showed you here in that simple slide, no.
Okay.
That was just the descriptives, what we're finding in our samples. The predictive models, where we also looked at changes over time, around that time would adjust for all the covariates. And you see generally the same thing.
Okay, thank you.
Yeah. I thought you were going to ask the question. At some point I said anxiety isn't related to cannabis use in kids in our sample. And then the machine learning data we just popped up there said that all of a sudden anxiety does look really important. That's something I thought you were going to, and we haven't been able to tease that out because we just got those data last week, but it's changing too.
Thank you.
Yeah. Historically, the data we looked at years ago, anxiety wasn't important. Now we need to look at it again because it seems like things are changing, and maybe we'd find a different story with new cohorts of kids who are going through Compass. So, thank you.
Hi. Thanks very much. Very interesting presentation. You said that you're using ArcView and GIS data collection information. The first question I have is, do you collect socioeconomic status? If not, are you trying to or think about connecting socioeconomic status based on the GIS information you collect to the cannabis use and illegal drug use?
Yeah, great question. So from the individual students, we collect a few things that would be indicators that are relevant. We don't specifically measure SES in kids because most of them have no idea. But we do measure weekly spending money, and we have a scale for family affluence. So relative to the people around them, are they more or less affluent, and how much weekly spending money they have. The weekly spending money we've always found with kids for substance use is the most important because that's the disposable income they have to purchase things to have fun. For the school catchment area, we have socioeconomic data for what's in the catchment area for the schools. That's why we link to the census. The most common one we use is the Gini coefficient, which is it's a deprivation index to tell you are they a more affluent or less affluent catchment area. So we can know for an individual kid whether they're more or less affluent, and then know whether they're in a more or less affluent school. So we can start to tease apart, are poor kids in a rich school worse off than rich kids in a poor school, or how does that tease apart? If you're really interested in that area, especially then linking onto some of our GIS data, we can have too. So one of our collaborators is Dr. Roman Pabayo, who's at the University of Alberta. He's our CRC, focused on socioeconomic differences, impacting health behavior, focused on kids. He's doing a lot of that work now with the Compass data to start teasing these things out with the repeat cross-sectional samples, but also looking at how being poor or rich in a more economically deprived or richer area impacts your likelihood of these things longitudinally as well. If you put a kid in a particular context, are they thriving or not thriving? We would also have some data to see if kids potentially switch schools, which I think would be really neat to see how trajectories change when you put them in a richer or poorer context as well.
But other than the pocket money, you don't have you didn't include the SES in your prediction models.
No, well, family affluence was in there. At this, we control for, depending on what model we're doing, if we're controlling for what's happening at the school or regional level, we would control for socioeconomic for the higher level hierarchy. Like, so if you think of it as a cluster model, we have the spending money and family affluence at the individual student level. Then at the school level, we'd also adjust and control for school catchment area affluence.
Thank you.
Yeah, you're welcome.
We do have a couple of online questions. So the first is, are females more likely to use cannabis in isolation than males?
Yes, from what we've seen preliminary, unadjusted.
The second is a little bit longer. Have you collected information about the type of vape that youth are using most frequently? Are they using distillates or no plant particles or hash oils or resin? There's a second part, but I'll let you answer the first part.
Unfortunately, no. We just know whether or not they're vaping. And so we have we have measures around, are they vaping traditional nicotine-based vapes, or are they using cannabis-based vapes? But we don't have details of what specific vape products those kids are using.
Okay, thank you.
Yeah, one of the downsides of this is, like, when we were funded, we weren't funded to evaluate cannabis legalization. We just happened to have really good data for looking at some of it while this natural experiment was happening. So we do wish we had more data on certain topics, but we're kind of trying to do the best we can. The neat thing that people aren't often looking at is how cannabis relates to all these other important aspects of youth development that I think we can look at that other people are ignoring, because most substance use surveys with kids are focused only on substance use. They're not focused on all the other things that are happening within a kid's life.
Great presentation, Scott. Your data are very similar in some ways to the data we see from our young adult substance use program at St. Joe's, which is for youth 17 to 25. But basically, cannabis is a fellow traveler of lots of other substance use and lots of other mental health issues. And there's kind of a sense that the issues are not necessarily about cannabis, but a kind of syndrome of other problem behaviors. I don't know much about the adolescent area, but to what extent is there aggressive prevention programming or early intervention programming that might be in some of the schools that could be evaluated within the Compass system?
That's great. There's not a lot, if you want an unfortunate answer. When we look at what schools are doing, there isn't a lot happening in the cannabis portfolio, and that can be for a bunch of different reasons. One, schools have no idea what to do. Schools are not trained on how to provide substance use programming for kids. They need to have that distributed to them. When you think of what happened successfully, say, with tobacco control, there was a whole, provincial and national tobacco strategies designed, produce programs for school, community, et cetera, and then schools were fed, here's exactly what you should be doing, and this is what should work. For cannabis, there's nothing like that. What we look at, it's mostly prohibition of you're not allowed to use it on school property, and then some basic information about the health risks. And we know that knowledge typically doesn't often result in a change in behavior in kids. So not a lot has been done. A few, one-off programs have been implemented in schools. When we've evaluated them, they basically show no to limited impact because they tend to be very short-lived. So it's, you have one person come in, they do a presentation or two, and then they leave. It's not part of, what would provide a structural change to the way things are done or the information that's provided. I think part of the mistake too is they all tend to be substance specific. Like you were saying, kids are using for a variety of different reasons. Tobacco programming is still tobacco specific. Alcohol is alcohol specific. Cannabis is cannabis specific. But that's not how kids are using these products. They're using basically, it looks like a lot of the time, whatever they can get their hands on. So.
Thank you. And one other question. I noticed that you were including the DERS, the measure of emotional regulation, which I think is really interesting because a lot of the indicators are more behavioral or mental health related, and emotional regulation is kind of a mechanism you can intervene on. Can you describe some of the findings that are coming out with emotional regulation in your sample?
I could. It hasn't been looked at a ton, if you want an honest answer. More recently, we're looking at it because it's coming out in some of these models where you get away from the researcher bias. So if we're putting things in and seeing what the model produces, it seems to be coming out in kids. For people who've looked at, say, the mental health aspect related to substance use in kids, the focus largely tends to be around depression and anxiety for what people have been doing, because that's what people want to see. And that's the information, to tie it back into my last rambling answer, that's the information schools actually care about. If you talk to all the schools in Compass right now, the number one priority for all of them is mental health. That's the programming they want to be providing to kids, mental health programming. So now we're trying to figure out how do you make some links to mental health and substance use so they actually understand the importance of moving in that area. So it's been trending. We've focused a lot on depression and anxiety because that's what people wanted and that's what schools could understand. Now we're starting to focus a little bit more on emotional regulation. There's another pocket of people coming at this from a different issue, and two of the most important predictors for all these things we're starting to find are the concept of flourishing, just whether or not kids know how to thrive in the face of negative events. It's almost like a resilience measure, and school connectedness. It seems very simple, but kids who attend a school where they feel connected to their school are doing better on almost every single indicator we look at in Compass: physical activity, substance use, et cetera, et cetera, et cetera. So we're trying to look at those things more while adjusting for kids who may be more or less at risk from things like depression or anxiety. Very rambling way to say we haven't looked at emotional regulation a lot.
Thank you.
Can I ask a question?
Sure.
Great presentation. So actually, I want to ask you. So in your Compass system, did you collect the academic outcomes among the students? For example, the school GPA, school dropout rate, or school absenteeism. So because, so we understand cannabis and other substance is associated with a worse academic achievement. So that's why, can you link your Compass system with the school records about GPA or anything else?
Great question. So we ask students to report their highest grade in the previous year for math and English. We don't purposefully link to school academic records because then all of a sudden students think you can track who they are and they won't want to participate. So we purposefully don't do that. But kids will happily say what their grades are. And like you would expect, kids who tend to have better grades tend to not be taking a bunch of the risks that you'd see from the substance use side of things. In our Quebec sample moving forward, they want to do things slightly differently. There's very different buy-in in Quebec from the education system and the public health system, where they actually want to be able to link to education records, and then they'd have mechanisms in place to explain to kids why this can still be done confidentially. They also want the potential to link to hospital admission data for the Children's Hospital there to start to see how some of these things, link to some of the health service side of things. It all depends on context. What we can measure in Ontario is different politically than what we can measure in BC, different than Quebec, for example. So yes, we know what their average marks are, but we don't have it linked to specific what their grades were as reported by the school.
Thank you.
If you want a charged field to try to do research, try doing adolescent health research. It's very complicated because of all the different political things we have to worry about and focus on when we're trying to collect these data, what we can measure and what we can't measure in different jurisdictions.